regurgitation. My topic is about tricuspid valve regurgitation, how to quantify and when to treat. And actually, we all know that tricuspid regurgitation is very high prevalent and untreated among the elderly population. And there is a great anatomic variability of the tricuspid valve, with the most common subtype for the posterior valve to be divided into two leaflets. And we can classify the tricuspid valve regurgitation in primary, secondary, which can be atrial or ventricular, and related to some lead or ICD or pacemaker. We can classify or we can quantify the tricuspid valve regurgitation with a transthoracic echo. If the vena contracta diameter is more than 7 to 14, then that's a severe one. If it's more than 14 millimeter, is a massive one, and if it's more than 21, then we talk about torrential tricuspid valve regurgitation. Of course, we can also take into consideration the EROA, the regurgitation volume, the diameter of the inferior vena cava, and other echocardiographic parameters. But I think the main problem and the main question is when should we perform an intervention with the tricuspid valve regurgitation. And there are no clear guidelines so far. We have to discuss it in the heart team and consider different aspects. The recommendations of the guidelines about the treatment of the valve disease, the morphology of the valve, the availability of echocardiographic imaging windows, the right valve, the right ventricular function, and the presence of pulmonary hypertension, the presence of leads, the concomitant, of course, cardiac abnormalities, and the surgical risk of the patient. And there is a consensus paper from the European Heart Failure Association and the EAPCI, which puts in the center the secondary tricuspid regurgitation and describes different pathophysiologies and clinical entities which can affect the remodeling of the right atrium with HFpEF and atrial fibrillation, or primary precapillary pulmonary hypertension, pulmonary disorders, pressure overload, or post-capillary hypertension. And of course, the tricuspid regurgitation can affect different systems, can cause hepatic dysfunction, renal failure, malabsorption, brain damage, and pulmonary congestion. We see that the more severe tricuspid regurgitation becomes, the more severe becomes also the symptoms of our patient. And there are some red flags about the early identification and the treatment of the tricuspid regurgitation. Dyspepsia, abdominal distension, fatigue, signs of right heart failure and systolic murmur, and of course, an impaired renal failure, renal function, or a renal failure, and high cholestatic markers are red flags affecting the recognition and the treatment of the tricuspid regurgitation. The intervention has to be on the right the time, I mean, not too late, because then it's important to be on time. But are there actually any patient or clinical characteristics that predict the success of the treatment? Not many, because the pivotal trials exclude patients with untreated valvular lesions, with LV dysfunction, with uncontrolled hypertension, or with precapillary pulmonary hypertension. We know that the cardiohepatic syndrome carries a very bad prognosis, and we know that there are a lot of challenges of the tricuspid valve imaging, because it's a very fragile anatomy. It's high load dependent. We work in an environment of low pressure. A lot of times we have leads, we have artifacts of the bioprosthetic valves, and we have less experience than working on the left side. And mainly, we assess the severity of the tricuspid regurgitation with the echo. We can also use MRI or CT. And of course, we have to perform a right heart catheterization to distinguish between post and pre-capillary pulmonary hypertension. We know that the precapillary hypertension, pulmonary hypertension carries a bad prognosis. We have to measure the cardiac output. We know that the very low or the very high cardiac output also is associated with worse, with lower survival, and of course that the very high pressure after diuretics carries a bad or a worse prognosis. There is a work from Germany about the hemodynamic profile, which predicts mortality after tricuspid valve repair. And they have shown that the elevated MPAP, the mean pressure, and the TPG, and the combination of the both carries worse prognosis. There is, of course, the well-known TAPSE to RVSP, that if it's more 0.4, carries a good prognosis for the patient after the intervention. And the good candidate for TEER has good TOE imaging windows, has a primary TR with prolapse or a secondary with normal leaflets, has a coaptation cuff less than 4 or less than 7, and the main jet comes from the anteroseptal part of the leaflet. Echo is very important to quantify the severity and the mechanism, to determine the morphology of the leaflets and possible anatomic variations, to assess the anatomy and exclude any potential adverse features. It's very important to take the commissural view between 50 and 70 and take a biplane or a multi-D to put the color and see the maximum color where it comes from. We have to take the transgastric views to assess the anatomy of the valve. We could also take some 3D pictures, but it's not always that easy. It's important to measure the leaflet lengths, the number of the leaflets, where the color comes from, and the location and the extension of the caps. It's also a good practice to have the tricuspid TEER score that predicts the success of the intervention. Another index is the leaflet to annulus index, but the most important thing is the coaptation gap. It's a predictor of the procedural success. The Triluminate pivotal trial, after 2 years, shows a clear reduction in the hospitalization for heart failure, and also an improvement in the quality of life. But Tricuspid TEER is also safe and effective. And there is also it's a FR trial for France in 24 centers that also confirms the results and shows a clear reduction in the heart failure hospitalizations. In conclusion, we have to consider before the tricuspid valve regurgitation interventions, we have to consider the leaflet length, the location of the TR, the annular diameter, possible leaflet restriction, the number of the leaflets, the presence of the leads, and of course the coaptation gap. The good, the easy scenario is the one with the small gaps with septal location of the jet with a favorable leaflet annular index and a good leaflet morphology. The TTTVR is and remains the first line treatment for TR because it's safe, because of the efficacy, durability of the growing eligible population, because of the expanding number of patients and growing experience globally, and because of the respect for the native anatomy and because of the quick patient recovery. It's actually the only evidence-based tricuspid therapy on a large-scale trial compared with medical therapy. It's important to recognize early the right patient, to select the right patient, and to find the characteristics of the valve morphology that are predictive of a successful TTTVR. Thank you very much.
Well, let's make a little question here. You hear these presentations, everything sounds great, but the numbers of the people ultimately having the tricuspid interventions are low. So the problem is there's a question in people's mind that TEER is not effective, or I don't know, there are not that many clear indications when to proceed, because we say we proceed early, but then early patients don't have many symptoms. So, non-invasive cardiologists and clinical cardiologists may be hesitant to agree. And you have a heart team can say early, you may not even see the patient because nobody considers or thinks of it so early, let alone there would be questions at the heart team itself if someone comes early. Why approve it? Patients may have minimum of mild symptoms. Would you be comfortable referring patients or just based on echo presentations and minimal symptoms? Is that, or atypical symptoms, or, what do you think, George? You're expert in echocardiography, and also how do we combine that with clinical in order to achieve early, not as part of a lecture, but as a part of reality?
Well, it is a crucial point you gave us. In practice, there is a recent publication in the European Journal stating once more that the best outcomes post-TEER of this scenario is with more than severe tricuspid regurgitation. So we are lagging behind for the proper definition of not only severe, but more than severe. So the issue becomes very complex in decision-making according to your clinical point. So when there is a necessity, according to the current sub-analysis of the TRISCEND-2 trial, which reiterates the importance of having more than severe TR, we are now confused how to delineate in clinical practice the more than severe TR and to make the proper timely wise decision. I don't know, what's your opinion, Dr. Sari?
I agree. I think that it's crucial to define where is the best timing, not perform the procedure too early, because you don't want to take a mildly symptomatic patient into invasive procedures that have sometimes, although it's a safe procedure, sometimes you get some unexpected results, but you don't want to delay the procedure. And unfortunately, in my experience, most of the patients that do arrive to the procedure came in their advanced stage of the procedure with hepatic failure, with cirrhosis, and those patients you do not really change the course of the disease. So I think we should go early. Don't wait for the organs, the target organs to deteriorate. Don't get to the creatinine of 2 or hepatic failure. This is too late. I suggest that you go for the symptomatic patients before there is a damage to other organs. Those patients can benefit, and you can also change the course of the disease. If you're going too early, it might be not necessary, but unfortunately, most of the cases are treated too late, and therefore you do not really get the benefit you expect.
By the way, the surgeons also say the same thing when we talk to them about the tricuspid surgery. They say, sure, we got to operate early. I mean, nobody understands how that early is from clinical point of view. That's a key point. You have a question?
Yes. Go ahead. Thank you. For the first time in the 2025 guidelines, the European guidelines, we have numbers. We have 6 numbers. They tell us when the right ventricle begins to fail, and when the right ventricle is too advanced and the intervention is futile. Why don't we respect these 6 numbers concerning the TDI, the TAPS, the free wall strain, the ejection fracture, and is there any discrepancy between the necessity to have symptoms, which is an advanced stage, and the numbers that tell us that the right ventricle begins to fail?
Well, this issue has been discussed thoroughly in the background of the guidelines. There is a confusion about how to evaluate RV function in the presence of an increased preload, first. And second, quite often in clinical practice, in the majority of these patients, there is also a component from the left side. In practice, George, with your experience, in practice, we don't see very isolated tricuspid regurgitation. Usually, our experience is that the wedge pressure, usually in this scenario, is around 20-25. In the trials, the patients selected for the trials have a mean wedge around 15. So the trials actually have excluded the real clinical scenario. So in the guidelines, the numbers which are given and promoted are not related, Nikos, to the reality of handling severe tricuspid regurgitation. This is my point. I have a long discussion, and we're lucky that in this session I've invited from Italy, Luigi Badano, who has done a great job with his team upon this issue of how to evaluate the right ventricular function within this pathophysiological context.
Well, let's go back to Dr. Ninios. With respect to this discussion we're having, that is it mostly, are we, I think, mostly deferred to severe TR and these related indices by echo? And proceed with procedure even with abdominal vague problems sometimes? How do you put together in your center this type of referral basis and building the indication for the procedure where the symptoms are mild or atypical?
Thank you for the question. I haven't had everything because I have some sound problems. If I have understood right, the question is how do we make the decision to proceed with tricuspid intervention?
Yes.
Yes. Okay. I think a very important part is how the patient feels. I mean, the presence of heart failure symptoms, the NIHA class of the patient. The second one, for me, is the red flag. And of course, the presence of renal failure to proceed with the intervention. Because there are a lot of patients with severe or massive tricuspid regurgitation who don't have any symptoms at all or don't have a great need of diuretics.
Well, notwithstanding the sound problems, we understood the general impression. Let's go ahead with Dr. Chrissoheris, who's going to